As our next guest, I would like to invite Dr. Professor Oscar Traynor for his talk. It's a privilege to have him here. He is a professor of postgraduate surgical education in the Royal College of Surgeons in Ireland, and he's going to talk. He's going to talk about the future of
Mr. Chairman, ladies and gentlemen, good afternoon. I would like firstly to thank the organizers of this conference, and particularly Professor Kaya Jorgensi, for inviting me to speak here today. It is a great honor for me to speak at this conference in Ankara. I will be speaking on the subject of how should we train our surgeons of tomorrow. Now, for those who do not know, Ireland is a very small island nation on the western extremity of Europe. We have a population of just 5 million people, which means that the population of our entire country is roughly the same as the population of the city of Ankara. Dublin is our capital city, and Dublin is approximately 3,250 kilometers from Ankara. Now, although we are a small country, we do have a very strong tradition in surgical training, dating back to 1784, the time of the foundation of the Royal College of Surgeons in Ireland. I'd like to start by introducing Anusha and Steve. These are two astronauts who are just about to go on their first space mission. Now, although they have never been in space before, they are already fully trained and competent, not only in the technical skills required to actually fly the spacecraft, but also in the non-technical skills required to deal with every conceivable situation which might occur whilst they're in space. And all of this training, every bit of it, has taken place through simulation. It had to, because NASA doesn't actually do training flights. The first time you go in space, you are on your own. But not only have they been trained through simulation, they have also been assessed and assessed and assessed, using very objective and robust assessment methodologies. And all of these assessments have been carefully documented and logged, so that as they set off on their first space mission, NASA has 100% confidence that they can safely and competently complete their mission. Now, wouldn't it be great if we could do the same thing with surgery? Wouldn't it be great if the first time a surgeon went into the operating room, she or he already had the skills necessary to complete the procedure safely and competently? And why not? Because actually, astronaut training is not unique. We know that the same thing happens in aviation. No commercial airline in the world would allow a trainee pilot anywhere near the cockpit of one of its $100 million aircraft unless they had already completed the vast bulk of their training in the simulator. And just like the astronauts, they train in both technical and non-technical skills. And just like the astronauts, they place a major emphasis on assessment, verification, and documentation of competence. And the same thing happens in the military. The battlefield is not the place to learn military tactics, but instead they learn through simulations and reenactments of scenarios. And increasingly, they use technologies such as augmented reality and virtual reality. I could quote countless other examples from the nuclear power industry, the oil industry, and many others. But my point is simply this. In the 21st century, simulation is the preferred model of training for industries, occupations, or activities that involve a high degree of risk to human life. Now, surgery is an activity that involves a high degree of risk to human life. But right now, we train our future surgeons using a model of training that was developed not in the 21st century, not in the 20th century, but in the 19th century. We've heard already this afternoon about the Halsted apprenticeship model. Halsted was a great American surgeon based in Johns Hopkins Hospital in Baltimore, Maryland, towards the end of the 19th century. And it was he who introduced this apprenticeship residency model to surgical training. Apprenticeship in surgery is no different in principle to apprenticeship in any other craft-based trade, like carpentry, plumbing, or electricity. Essentially, an apprentice or trainee is attached to a master or trainer, and they learn, first by watching the master at work, then by doing parts of tasks under supervision, then by doing full tasks under supervision, and then by doing full tasks under progressively less supervision until they are deemed competent to perform independently. That's what apprenticeship is, that's how it works. And in surgical training, apprenticeship has worked very well for well over 100 years. But there are two ingredients which are essential to the success of apprenticeship. The first is the opportunity to perform a large volume of repeated practice, and that involves working long hours over many years. And the second is the professional relationship that develops with the trainer, a relationship in which the trainer really comes to know the strengths and weaknesses of the trainee. Over the past 15 years, we have seen significant challenges to this traditional apprenticeship model of training. Firstly, there are pressures in most countries to reduce the duration of surgical training and to make it more streamlined and more cost efficient. But more significantly, there are regulatory restrictions on the working hours of residents. In Europe, as many of you know, the European Working Time Directive now restricts the working hours to 48 hours a week. And that is a dramatic reduction in working hours compared to even 15 or 20 years ago. These two factors have impacted on those essential ingredients that I just mentioned. Firstly, the opportunity to perform a large volume of repeated practice, and secondly, the relationship between the trainee and their trainer. But that's not all. We also have seen a massive increase in the amount of technology involved in surgical practice. And these technologies make it more difficult for trainees, particularly more junior trainees, to perform surgical procedures. There's also an increasing focus on meeting service targets, and that means that operating lists must be completed as quickly and as efficiently as possible, and that impacts on the amount of time available for training trainees. And finally, there are changing public expectations. The public no longer wish to be used as training material for young surgeons, and instead they, quite understandably, want their operation performed by the most senior, most experienced member of the team. And lastly, there is a requirement on training programs to both verify and document the competence of trainees. The collective consequence of all of these challenges is that the traditional model, the apprenticeship model, which has served us so well for nearly 130 years, is really struggling to survive. And we urgently need to design a new approach to surgical training for the future. But as we look to the future and try to design a new model for training, one of the problems is that we don't really know what surgery will look like 20 years from now. And it's very hard to design a training program for an unknown future. But there are some things about surgery that we do know. Firstly, we know that surgery, the practice of surgery, is becoming more and more embedded in complex technology. Technologies such as robotic surgery, advanced image-guided surgery, microsurgery, computer-assisted surgery. These are just some examples of the way that technology is changing the way that surgery is performed. And surgeons of the future will need to learn not only how to do the operation, but also how to use the technology. And it is simply not appropriate that that learning should take place in the real operating theatre, working on real live patients. Learning how to use the technology should take place off-site through simulation, where patients are not at risk. But the pace of change of technology is such that surgeons in practice who finished their training many years earlier will need to come back and be upskilled and retrained at a regular interval in the future, just as airline pilots do when new aircraft are being introduced into service. When I was going through training, the skills that I learned during the 12 years of my training program were pretty much enough to see me through my entire professional lifetime. That will not be the case in the future. Surgeons in practice, experienced surgeons, will need to come back on a regular, recurrent basis for upskilling and retraining. We also know that the people involved in the delivery of surgical healthcare are going to change very significantly. The traditional surgical team consisted of surgeons, anaesthetists, and nurses. We had a very pyramidal structure, and the surgeon was at the pinnacle of that pyramid. Everyone knew who was in charge. The surgeon was in charge. The surgical team of the future will have a much flatter hierarchy, and the surgeon will be just one member of a large, multidisciplinary, multi-professional team. And our surgeons of the future will need to be trained not only in the technical skills, but also in the non-technical skills required to function effectively as part of this multidisciplinary team. We also know that there is an increasing emphasis on the processes around healthcare, and particularly around surgical healthcare. Our surgeons of the future will need to not only know how to operate and have the non-technical skills required, they will also need to have a sound knowledge of areas like healthcare economics, healthcare management, process improvement, clinical governance and patient safety, information technology, surgical innovation and medical device innovation, and global surgery. It is a shameful statistic that today, in 2018, 65% of the population of this planet do not have adequate access to safe surgical healthcare. 5 billion people do not have access to safe surgical healthcare. That is something that we as surgeons cannot ignore. We cannot solve the problem on our own, but we need to become part of the solution. So, in the Royal College of Surgeons in Ireland, we have, over the past few years, fundamentally redesigned our approach to surgical training of the future. And we've drawn from the experiences of other high-risk industries like aviation and military defense forces to embed the use of simulation in surgical training. We have recently opened a new okay, we've missed a slide there, but we've recently opened a new 80 million euro state-of-the-art education and training building, which includes 3 floors dedicated exclusively to simulation. And so all of our surgical trainees come to this center on a regular, recurrent basis throughout their surgical training, from the very junior stage right up to the very senior stage. And they receive regular, recurrent training through simulation. Now, I should say at this point that simulation in surgical training is actually a complete waste of time and money, unless it is embedded in the curriculum for surgical training. So it's not just about coming in and using the simulators. Surgical trainees really enjoy using the virtual reality simulators, but it has to be more than just playing with the toys. There has to be clearly defined learning outcomes, goals that they have to achieve, and it has to be tied into an assessment framework so that they can be signed off on their competencies. Within our surgical training center, we have a very large wet lab. By that I mean a lab where we can use biological specimens, either animal cadavers or human cadavers. We also have a dry lab where we can use our virtual reality simulators. We have a fully equipped mock operating room, and we have 18 simulation rooms that can be used as hospital wards, or as an outpatient clinic, or as emergency department. Our trainees are supported by the use of a smartphone app called Cerrahi, which we developed ourselves in our college, and which contains a wealth of educational resources for the surgical trainees. So there are videos on basic surgical skills like knot tying and suturing, and there are also videos of core operative procedures like laparoscopic appendicectomy. Surgical training in our country starts with a surgical boot camp. So this is in the very first week of surgical training, before they even start in the hospital. Our surgical trainees come in for a 5-day introductory course in surgical skills and management. Each day they spend 8 hours in the simulation center. 4 hours in the morning are spent learning technical skills like knot tying, suturing, wound closure, anastomosis, drains and catheters, minor surgical procedures, and laparoscopy and endoscopy. And then in the afternoon, they do 4 hours of non-technical skills, where they learn critical care, emergency care, an approach to clinical decision-making, management of common surgical problems, risk management, and various aspects of caring for yourself in a surgical career. So this very intensive boot camp happens at the very first week of surgical training. And then during each year of training, they come in 6 full days each year, 6 separate days. They're not grouped together, they're spread out over the year. For each of these training days, they spend the first 1 hour in the anatomy department, where they learn the surgical anatomy relevant to the procedures they're going to be learning that day. We are fortunate that we have an undergraduate medical school in our college, and therefore we have a full anatomy department with anatomy teachers and professors. After the first hour, they then move across to the surgical skills lab, where they learn surgical skills according to a predefined syllabus. And the principles of learning are, firstly, demonstration, where a senior tutor demonstrates the procedure. Then they practice. Then they get proximate or early feedback. Then they get coaching, that's showing how to do it better. And finally, assessment. And that is the principles which underlie all of our training days. For more elaborate procedures, they work in our biological or wet lab. So this is some photographs from our biological lab. And as you can see, they look for all the world like a real operating theatre. They have all the equipment, monitors, services, lighting, just as in a real operating theatre. And they work usually on animal cadavers. We don't do live animal surgery, but we use animal cadavers. They paint and drape just as they would in real operating theatre. And they have tuition from tutors with a high tutor-to-trainee ratio. Everything they do is recorded with these video recorders so that we can track the progress of trainees over time, and we can compare the progress of trainees with their peers who are at the same level of training. What we are trying to do is to get our trainees to a stage of expert performance through the concept of deliberate practice. And deliberate practice needs to be purposeful and goal-oriented. So there need to be clearly defined goals and outcomes for each intervention that takes place. Now, just a word about the training models that we use. It's important for a simulation center to have a wide range of training models. For simple, basic surgical tasks like knot tying and suturing, we use simple, inexpensive models, commercially available models like this jig for teaching knot tying. For intermediate procedures like inguinal hernia repair, we use commercially available synthetic models. For endoscopy and laparoscopy, we use high-end virtual reality simulators. For other procedures, we use animal cadavers, either animal parts, such as this pig's trotter for teaching tendon repair, or a full animal cadaver for teaching laparoscopic intra-abdominal surgery. And at the very highest end of the scale, for certain very complex procedures, we use fresh frozen human cadavers. So for certain procedures like arthroscopy of the knee, or axillary lymph node dissection, or hand surgery, or facial surgery, really for these there is no substitute to using the human cadaver. But it would make no sense to use a cadaver, a fresh cadaver, for teaching basic skills like knot tying or suturing. They can be taught just as well using inexpensive models. All of our trainees go through an annual skills assessment. So they go through a number of different OSCE-type OSATs stations where they have to perform procedures that they've learned that year. These are high-stakes assessments in the sense that they do count towards career progression in surgery. Now, so far I've spoken just about the technical skills. What about non-technical skills? As surgeons, we all work in a complex environment. An environment in which complex interactions take place between human beings and other human beings on the one hand, and between human beings and machines or technology on the other hand. And in such a complex environment, the potential for critical events to occur is enormous. And the way that we behave at the time of those critical events has a profound impact on clinical outcomes and patient safety. In a nutshell, that's what human factors is all about. It's about the way that we interact with our environment, with other human beings and with machines or technology, and the impact that that has on clinical outcomes and patient safety. At the Royal College of Surgeons in Ireland, we have placed a great emphasis on human factors training for more than 15 years now. We run a human factors program, which is a mandatory part of training for all of our surgical trainees. And this program includes things like personality and behavior, human performance and error, communication skills, negotiation and conflict resolution, teamwork and leadership, decision-making and judgment, and various aspects of human overload. Now, this is not a didactic program. This is a program which uses simulation to teach. And where possible, as far as possible, we employ the full surgical team, not just surgeons, but also anesthetic trainees and advanced nursing trainees. And they come in and perform realistic simulations in the mock operating room or in the mock emergency department, or on the wards. They get a briefing, then they enact the scenario, and then there is a detailed debriefing based on video recordings of what takes place during the scenarios. There is regular reinforcement. Every trainee must come 3 times per year for this type of training. And at the end of each year, there's a formal assessment, just as there is for the technical skills. So our human factors assessments take place in the mock operating room. As you can see here, it's a very realistic scenario with a patient draped, painted, full anesthetic equipment, everyone is scrubbed up, or they could be in the emergency department, or it could be on one of the wards. So they are formally assessed using objective assessment methodologies. And just like the technical skills assessments, these assessments count towards career progression. We also have the facility to undertake simulations of ward rounds and outpatients and nights on call in the emergency department. So for these type of simulations, we use simulated patients. These are members of the public who have volunteered to be simulated patients, and we give those members of the public specific training in what to say and how to react. So on the ward rounds, our trainees learn preoperative and postoperative management, team interactions, leading a ward round, documentation of care. In the outpatients, they learn consultation skills, how to manage angry or upset patients or relatives, how to do informed consent. And in the emergency department, they learn about crisis management, triage and prioritization of care, and conflict resolution. What we are aiming to achieve through simulation is to deliver a program which supplements the hospital-based training program and is based on a clearly defined curriculum. It encourages the concept of deliberate practice through simulation. It includes a blend of both technical and non-technical skills. There is formal assessment as an integral part of our program. And finally, we employ professional trainers. Our trainers in the Simulation Center are specifically trained in simulation. What we are hoping to achieve is competence by design rather than competence by time. Thank you.
Thank you very much, Professor Traynor, for your highly inspiring talk. I have a question. What do you think about, or do you use frequently virtual reality in your education?
Yes, I think virtual reality has a lot of potential. I think in surgical training, it's still at a very early stage. But in our college, we have employed people, non-medical people, specifically to design virtual reality simulation programs for surgical training. So we have a number of programs which can be used with virtual reality. I think it has a lot of potential, but it's at a fairly early stage just yet.
Mm-hmm. Probably with the advancement of robotic surgery, it's almost parallel to robotic surgeries. With the advancement of robotic surgery, probably virtual reality training will be more and more available.
Yes, I think that's absolutely correct. Yeah, absolutely.
Any questions, comments? Dr. Abbasoğlu?
Professor Traynor, thank you very much for your informative and very comprehensive talk. I know that you are an experienced surgeon and you have a lot of experience in simulation training. My question is rather controversial. Do you have any concerns, or do you think that there are some disadvantages of simulated training?
Well, I think...
In other words, should we be cautious regarding certain points? about simulation-based training?
Yeah. I think simulation-based training will never replace training in the workplace. I would see it as an adjunct to training in the hospital rather than a substitute. It will never replace it, but it allows the trainees to get better value out of their clinical training in the workplace because they have the skills, they've acquired the skills in a safe environment, and they've been assessed and signed off on their skills before they use them on real patients, hopefully. So it will never be a substitute for clinical training. It's more of an adjunct which complements surgical training in the workplace.
Dr. Yorganca.
Thank you very much, Professor Traynor. I have two questions. The first one is, during a residency program for one resident, 8 years program, how much they spend their time in the clinic, in the OR, or in the outside the hospital, in your simulation laboratory, or etc.?
Okay, so in their first year, they spend 5 days doing their surgical boot camp, and then 6 further days doing technical skills, and 3 days doing human factors. For each subsequent year, there's no boot camp. They just come 6 days per year for their technical skills and 3 days for human factors training. So it's 9 days every year throughout the whole 8 years of training.
Okay, so the second question is, Ireland is a 5 million country, and I see that you have an excellent educational program. How can we adapt this program to an 80 million population country? It needs another complicated organization, or what?
Well, I think firstly it needs people who are enthusiastic about simulation and who are convinced that simulation is valuable. But it also needs financial support. Simulation is not cheap, and so you need to have financial support from government. We are very fortunate that our government have seen the value of simulation and are prepared to support it. So without that support, it's very difficult to buy the simulators because they're quite expensive, most of those simulators. So you do need financial support.
Buyurun.
Hi, Dr. Traynor. I'm a fifth-year medical student here. Your talk was really enlightening. Thank you for that. I have a question. When did the Simulation Center, when was it opened for the students in terms of the year?
Okay, so when did our center open?
Yeah, because I have a question. In this amount of time, do you guys find it cost-effective since it's 18 million euros?
Yeah, so our center, we first started using simulation in 2003, so 15 years ago. The building that I was showing you there opened just 1 year ago. So prior to that, we were using rooms that had been converted. So they were not specifically designed as a simulation center. Our new building has been purpose-built and purpose-designed. We knew in advance exactly what we needed, and so obviously that's much better. In the 15 years that we've been using simulation, we have received very positive feedback from both trainees and also from trainers who say that the trainees coming to them have much better skills than they had in the past because they learn them and they can repeatedly perform these skills in the skills lab. So it's a much more efficient and safe way of learning skills than learning them on real patients.
So you would say it's cost-effective then?
Absolutely, yes.
Thank you.
Any other questions, comments? topics. You have this center in Dublin, I think, right?
Yes, yeah.
And how many medical schools do you have?
Medical schools, we have 6 medical schools in Ireland.
In different cities? In different cities? Are they in different cities?
Oh, in different cities, yes, they are. There are 3 in Dublin, 1 in Cork, 1 in Galway, and 1 in Limerick.
So,
So
from the other 3 cities, they come in kind of rotation? They do rotation?
yes, in Ireland, surgical trainees never do all their training in one hospital. All trainees rotate every 12 months. So even if they graduated from a hospital in Dublin, every 12 months they would rotate to other hospitals. So they get to see other hospitals around the country. So that's a little different to, for example, in the United States, and I believe here as well, where everyone stays in their own hospital throughout their training. In Ireland, every trainee rotates every 12 months.
Do you believe that's better for education?
I think it's better for surgical training, but to be honest with you, in recent years, a lot of the trainees are saying to us that this is not easy for them in terms of families. It's not a family-friendly way of organizing surgical training.
Right.
So we may need to relook at that at some stage.
Okay. Thank you very much. And